before we dive in, do 3 quick things that really help us. Subscribe to the channel, like this episode, and drop your next topic request in the comments. All set? Great, let's begin. Welcome to episode 5 of case-based scenarios on maternal health and pregnancy care, antenatal screening, managing anemia in pregnancy, and how frontline workers like ASHA support home-based newborn care. Dr. Sharon, thanks for being here.
Delighted. Keep 2 national anchors on your fingertips for exams. Anemia Mukt Bharat, which uses the 6x6x6 strategy and mandates daily iron folic acid for pregnant women. And home-based newborn care with a fixed postnatal visit schedule for ASHAs. Quote them explicitly.
Scenario 1. A 24-week pregnant woman has hemoglobin 6 grams per deciliter. How do we classify severity and manage this specific case? Also, what programs support supplementation?
Classification first. In pregnancy, severe anemia is hemoglobin less than 7 grams per deciliter. So at 6 grams per deciliter, this is severe and needs urgent inpatient management. Management, write it as a short protocol. Stabilize and evaluate, check vitals, rule out cardiac failure, assess for causes, nutritional iron deficiency, helminths, malaria where relevant, send a complete blood count and peripheral smear if indicated. Rapid iron repletion, use parenteral iron, intravenous iron sucrose or ferric carboxymaltose, which Indian guidance and recent evidence endorse for moderate to severe anemia, especially in second or third trimester, or when oral iron is not feasible. Consider packed red cell transfusion if decompensated or very low hemoglobin with risk. Adjuncts, deworming in second trimester, nutrition counseling, folate, and close follow-up. Program linkage, under Anemia Mukt Bharat, pregnant women receive 1 iron folic acid tablet daily from the second trimester, continued for at least 180 days in pregnancy and 180 days postpartum. Each tablet contains 60 mg elemental iron plus 500 micrograms folic acid. Document on the MCP card and ensure supply continuity. Pause and recall, which national platform guarantees a minimum of 180 days of daily iron folic acid in pregnancy? Answer, Anemia Mukt Bharat.
Scenario 2. Malati delivered at home. ASHA visited on the same day. Birth weight 2.2 kilograms. First, comment on the weight. Second, how many subsequent ASHA visits are needed? Third, what advice should be given about the baby's progress and kangaroo mother care?
First, low birth weight. WHO defines LBW as less than 2,500 grams. So 2.2 kilograms is LBW, hence higher risk. Second, home-based newborn care visit schedule. After a home delivery, it is 7 visits. Day 1, within 24 hours, 3, 7, 14, 21, 28, and 42. For institutional deliveries, it is 6 visits, days 3 to 42. Extra visits are advised for preterm, LBW, or sick newborns. Write the 7-visit line exactly. Examiners look for it. Third, advice and kangaroo mother care. Counsel on exclusive breastfeeding, feeding at least every 2 to 3 hours, maintaining warmth, hand hygiene, and recognizing danger signs. Poor feeding, fast breathing, fever or low temperature, lethargy, and convulsions. For a 2.2 kilogram infant, start kangaroo mother care. Early, prolonged skin-to-skin contact with the mother or a substitute, plus exclusive and frequent breastfeeding. Encourage many hours per day and continuation at home once stable. This is exactly how India's operational guidelines describe KMC in LBW care. Pause and reflect. Which single practice both prevents hypothermia and supports feeding in LBW babies at home? Answer, KMC, skin to skin plus exclusive breastfeeding.
Scenario 3. A 20-year-old primi bravida delivered in a PHC. Birth weight 2.2 kilograms. Define LBW, list common Indian causes and specific risks.
Definition to write verbatim. LBW equals birth weight less than 2,500 grams regardless of gestational age. Common Indian causes are prematurity, intrauterine growth restriction related to maternal undernutrition and Indian iron deficiency anemia, teenage pregnancy, short interpregnancy interval, hypertensive disorders, tobacco exposure, heavy physical work, infections, and inadequate antenatal care. These risks mirror WHO and national newborn planning perspectives.
Scenario 4. A third trimester pregnant woman presents with high blood pressure and pedal edema. Define pre-eclampsia and eclampsia and list warning signs that must be explained for immediate referral.
Pre-eclampsia is new-onset hypertension after 20 weeks. That is, blood pressure at least 140 over 90 millimeters of mercury with proteinuria and or end organ dysfunction. Eclampsia is seizures in a woman with pre-eclampsia not explained by another cause. Indian program materials under Pradhan Mantri Surakshit Matritwa Abhiyan use the same threshold and emphasize the typical symptom cluster.
Danger signs to counsel clearly would be severe headache, blurring of vision, epigastric pain, oliguria, increasing edema, rising blood pressure, bleeding per vaginum, decreased or absent fetal movements, and any convulsion. Any of these requires immediate referral. ASHA should mobilize transport to an appropriate facility, FRU or higher. Pause and recall. What is the blood pressure threshold that should make you suspect pre-eclampsia after 20 weeks? Answer, at least 140 over 90 millimeters of mercury.
Could you summarize today's 4 scenarios with exam-ready phrasing?
Sure, think of it as a pocket script. First scenario, severe anemia at 24 weeks, HB 6 grams per deciliter. Classify severe, admit, evaluate, intravenous iron sucrose or ferric carboxymaltose with Indian guidance and recent evidence endorsed for moderate to severe anemia, especially in second or third trimester, or when oral iron is not feasible. Consider packed red cell transfusion if decompensated or very low hemoglobin with risk. Reinforce daily iron folic acid for a minimum of 180 days in pregnancy and 180 days postpartum under Anemia Mukt Bharat. Second scenario, home-delivered newborn, 2.2 kilograms, LBW, scheduled 7 ASHA visits, day 1, 3, 7, 14, 21, 28, and 42. Initiate Kangaroo mother care, skin-to-skin contact plus exclusive frequent breastfeeding. Teach danger signs. Third scenario, LBW definition and risks, less than 2,500 grams, list Indian causes, prematurity, growth restriction from undernutrition and anemia, teenage pregnancy, short spacing, hypertensive disorders, tobacco exposure, infections, inadequate antenatal care. Risks include hypothermia, hypoglycemia, sepsis, and later stunting and developmental delays. Fourth scenario, pre-eclampsia counseling, hypertension after 20 weeks with proteinuria or organ dysfunction, seizures equals eclampsia. Warning signs, severe headache, blurring vision, epigastric pain, oliguria, increasing edema, rising BP, bleeding per vaginum, decreased or absent fetal movements, any convulsion, refer immediately.
Before we wrap, one quick active recall drill.
Absolutely. Cutoff for severe anemia and pregnancy, less than 7 grams per deciliter. Exact HBNC schedule after home delivery, day 1, 3, 7, 14, 21, 28, and 42. One-line definition of LBW, less than 2,500 grams. Minimal statement defining pre-eclampsia. New onset BP greater than 140 over 90 after 20 weeks with proteinuria or organ dysfunction.
Perfect. Today we classified severe anemia at 24 weeks and linked it to Anemia Mukt Bharat, mapped ASHA postnatal home visit schedule and Kangaroo mother care, defined low birth weight with Indian causes and risks, and nailed pre-eclampsia and eclampsia counseling. Dr. Sharon, thanks for the crisp, exam-oriented walkthrough.
My pleasure. Keep the program names and exact phrases handy. That is what examiners listen for. And remember the pattern. Identify risk, link to program, write the actionable steps.